much for that. And let me go ahead and get back to sharing our slides. There we go. Okay. And I'm going to go ahead and move those. There we go. All right, so we are going to be moving on. Oops, there we go. Okay, so many people experience trauma. People with developmental disabilities, or obviously for you guys, folks on the autism spectrum, which is sort of developmental disabilities for me is sort of that umbrella, are at greater risk for being victimized or abused. So we already know that they're more liable to have big T trauma, but now let's look at some other things. So ordinary life trauma, being different, not being accepted, not being able to do what other people can do, moving to a new home or having a significant change where you live, knowing that you're different than other people in some way, not being listened to, being misunderstood, failing at a task, getting confused and overwhelmed. Now, when you look at this list, it might be kind of confusing because my guess is if we were all in the same room and I could see all of you guys, and I asked you, raise your hand if you have never, ever experienced even one thing on this list, even one time, none of you would raise your hands. And I know that for sure because I could have just as easily labeled this slide 7th grade, right? So this really is a list of things that can happen to any human being and happens to all of us, at least some of it, sometime or another. And so if it's kind of universal, then why are we including it in a presentation about trauma? And the reason for that is because we're not really talking about that sort of once in a lifetime disruption. Remember what we said about big T trauma before the break, that you maybe only experience one of those things on that list once to have it profoundly impact your life. The issue with this kind of trauma, which we call little T trauma, is not about intensity, it's about frequency. So this is more of that sort of cumulative stress, right? And so when you look at this list and think about some of the folks that you guys support, particularly feeling that you're different from other people or having a hard time communicating your needs or your feelings or getting confused and overwhelmed. If I asked you to rate, how many times a day do your folks experience that? You know, the answer for many of them might be, oh, they experience that all day, every day. And depending on how old some of the folks are that you work with, we might be talking day after day, week after week, month after month, after year after year, after decade, right? So that starts to add up to a lot of stress for a brain to process. And so one factor here is the frequency, not the intensity. But even with that, there's another element to it, and that is what are the resources and strengths that person has to deal with that? So in order to talk about that, I'm going to use you guys as an example, and I am not going to ask you to share this, neither not in your room or in your comments with me or anything like that, okay? This will stay with you. But I want you all to take a moment, and I want you to think about a time that you, let's see, that you failed at something, okay? And let's assume that this was something that was important to you, okay? It wasn't some trivial thing like, I guess water skiing's not for me, but like it was important to you and you tried hard and you really failed at it. Maybe other people saw you fail at it. And take a second and let yourself feel what that felt like. And I think that if I were in the same room with you, if I had all your faces on the screen, I would see the same thing, which is everybody kind of going, you know, we don't like how that feels. And in fact, I cheated a little bit. I'll go ahead and tell you this. I already knew something about you guys without having talked to any of you. And that is that picking something from the list like failing at a task is something that you guys are already very good at not experiencing. And I'll tell you why I know that. It's because you guys all have really responsible jobs. And so I already know that you really don't like failing, that most of you experience that as pretty stressful, and that you've got some pretty good resources about that. And I think that happens in a couple of ways. One is whatever resilience or skill set you personally possess to either, try again and study for that test again until you pass it, or you have the resources to do something else. So if you're like, I thought I was going to be an accountant, but then I'm terrible at math and I decided to go into social work, for example, um, you have the opportunity to choose a different path that will allow you to experience success when you're not going to experience it over here. Or you found out, I'm really good with people and I'm going to work in human services because that's where I can shine. So I know that hopefully most, if not all of you, have some of those resources. And another thing that I know that most, if hopefully all of you have, is you have supportive people in your life who are not paid to be there. And I want to be very clear about that. I know that the supports that the individuals have in you are very, very important to them. And I also am somebody who gets paid to be supportive to people because I'm a therapist. So this is not discounting or dissing that. It's simply to say that there really is something different when someone is in your life because they want to be, or that's an organic, natural role for them. We used to call those natural supports. I don't know if that's still current, versus someone whose job it is to be there for you. So those of you who have some supportive people in your life, and we know from research that it doesn't have to be a lot of people. It can just be one or two people who are there to say, don't worry, you'll get them next time. I think you're wonderful. That and having some of those skills and resources that you've developed help you not fail. So either you don't fail very much in the first place, or when you do experience a failure, you've got options for how you're going to change that story and put a different ending on it. And now ask yourself, how many of the folks we support in the field have those things? And some of them do, right? I'm not going to say it's nobody, but we certainly know that there are a lot of people who do not have a robust network of natural supports in their lives. If you think of it as like a cobweb, or a spider's web, some of them have webs that are made up of very few little strands. And that, by the way, a little side note, can be why grief and loss, which is something that I think is kind of the next thing that our field is going to really need to deal with, and that we don't talk about as much as I would like to. When you have a lot of strands to your web, then losing someone because a staff person takes another job or whatever, that may leave a hole, but it's a smaller hole than if you've only got a few strands in your web. So the lack of having a lot of natural supports really makes some of our folks more vulnerable to this kind of little t trauma, as well as the frequency of how often this happens. I think about people, for example, if you are working with folks on the autism spectrum, or as I like to use the autism wheel, where verbal expression is difficult, the difficulty they have communicating and being understood to other people, that is my personal nightmare. I cannot imagine just how stressful that would be. And we know, in fact, that, let's take autism again as an example, that having autism in and of itself may not necessarily be traumatizing. But if you are working with somebody who gets a lot of sensory overload and feels very overwhelmed and activated by that, or they struggle with being understood by other people or whatever it is, the cumulative effect of that can cause its own little t trauma. And so we know that having a developmental disability can make you more vulnerable to some of the big T traumas, exploitation, maltreatment, things like that. But also it can make you more vulnerable to these little T traumas. And so whenever people ask, well, how big of an issue is trauma for someone with any developmental disability? Actually, this is true for any disability at all, not just developmental disabilities, but also physical disabilities. But especially with DD, when you put those two things together, the big T and the little t, estimates are higher than 90%. Higher than 90%. So if you've got 100 people in a room and you tell them that more than 90 of them are dealing with something, for my money, you're kind of talking about everybody. right? So as we talk about what it means to offer trauma responsive care, how to be responsive to people who may have been affected by traumatic stress, we're talking about the population that we serve being more than 90% of them. And that is why we talk about trauma responsive care being a universal precaution, which we'll talk more about in a moment. Okay, so I love this quote. This person is actually a friend of mine and works a lot now in Ohio at the Ohio Board of, what is it now? Mental Health and Addiction Services. I can never remember the new acronym. But he works a lot with trauma for first responders. So people like highway patrol or law enforcement or EMTs or whatever. And when he trains them about big T and little t, he uses this little thing that I really like because it really sums it up. Big T is like being attacked by a bear, and little t is like being attacked by ducks, which is, kind of funny. It would not be funny if he used the example of geese because geese are terrifying. Ducks are adorable. Geese are the worst. I am terrified of geese. But anyway, the point, of course, I think is pretty obvious here, which is that an attack from a bear leaves obvious, immediate damage. No one's confused about that. With ducks, if it's one duck every once in a while that you've got to kind of fight off, all right, that might be something that you can handle. But given enough time and given enough ducks, that damage is going to start to look the same. But what happens is, again, just like when we talked about the difference between stress to the body or injury to the body versus hurt or trauma to the psyche or the emotions, we tend to think that one is worse than the other, and they're really not. Given enough time, that damage looks indistinguishable. So I really like how this captures how big T and little t fit together. Okay, so very quickly here, when we talk about trauma, again, we tend to talk about it as if it's like an adverse event. Somebody mistreated somebody else. But we also know that trauma is also a factor, especially in childhood, when it comes to something that threatens connection. Now, this is, again, even more true for young children, but I believe this is true throughout the lifespan. I work a lot with grief and loss in my private practice, and I know that sometimes people are coming to me not just dealing with grief, but also showing symptoms of trauma because the loss they experienced was so devastating. But let's talk about young children for a second. I think the benefits of those of you who work with children who, let's say, are on the spectrum and who are identified early, which we are getting better and better and better at, is that we can intervene and we can support, and we know how important that is for those developing brains, but also for the relationships between the children and the caregivers. Because anything that threatens that connection for young people, that brain will experience as life-threatening. Without going too far into this, this is part of a larger trauma training that I sometimes do. I will just say that when infants are born, their ability to connect to their caregiver is only slightly less important than having a brain that can run their heart and their lungs and to keep the mechanics of the body functioning, right? The first thing that develops in a fetus is that brain stem that will kind of run the body. The second thing is the limbic system, which is very involved in many different ways with attachment. And that is the second most important thing. The top part of the brain, dealing with executive function and language and lots of all these other things, that develops later. And as we know, kind of continues developing all the way into young adulthood. So what that tells us is that from an evolutionary standpoint, the ability to connect to a caregiver and get that nurturing and get that safety and protection is absolutely critical for that developing infant and young child. And when something threatens that, whether that's what we sometimes call poorness of fit, the parents were not prepared to be dealing with a child that is perhaps neurodiverse or has some kind of syndrome going on or whatever that might be. Or if the parents have their own stressors, they are dealing with their own mental illness or depression or addiction or violence or whatever it is. that brain will experience that disruption of connection and safety and care as trauma. For young people, right? So we're talking into like school age, high school years, whatever, their need to connect starts to become primarily social. And when something disrupts that because they are presenting in some neurodivergent way, or they're getting bullied, or whatever it is, that can be potentially traumatizing, even if that person is not being directly threatened or is being physically attacked in some way. So once again, this is just yet another lens of understanding that trauma is not just somebody doing something to the body, although it absolutely can be. It is whatever it is that the emotional brain experiences as overwhelming in terms of its ability to cope or connect. I could go on about this, but we're going to move on. I've kind of touched on these things, so I'm not going to spend a lot of time on them. I like to include them because those of you who, if any of you do actually do diagnosis or you have training in that, you will recognize these. Those of you who haven't, you're not going to be running around diagnosing people, but I always think it's helpful that if you are seeing young people or clients that you support or whatever, and they do have PTSD in their history as a diagnosis, kind of knowing what that means and how someone arrived at that. So to diagnose somebody with PTSD, there's some other criteria involving how long the symptoms have lasted and how long ago the event was, and some things we don't need to worry about. But the main thing, the heart of it, is there are these 4 areas of different kinds of symptoms, 4 different kinds of systems. Oh my gosh, symptoms, not systems. I'm a little tired. It's been a long day. So, and it's usually something like, I can't remember the numbers exactly, but you've got to have 6 out of 10 or 4 out of 9 of these symptoms in these clusters. So the first one we've talked about a bit, and that is hypervigilance, always on red alert. That I find often manifests somatically in the body. So you see the pacing, rocking, irritability, difficulty with sleep, stuff like that. It can also be things like somebody who needs to see their way out of the room, or they start getting agitated and freaked out. Hypervigilance simply means I can never let my guard down. If any of you work with teenagers, if you've ever worked in any residential settings as I did, bedtime was the power struggle. Before that, when we just had one phone, like a little payphone on the wall, the phone was a close second. But bedtime was always a huge thing. Now, some of that is because teenagers tend to be sort of natural vampires. There's actually an interesting theory as to why that is, that teenagers need to do a lot of brain pruning of those neural connections. And so there does seem to be a tendency for teenagers to want to be awake at night and asleep during the day. There's a theory that that might be to let them prune more of those neural pathways because they're less stimulated. They're more likely to be alone at night. So that's a little fun fact. But the biggest issue I've learned is that when you're hypervigilant, it can make it really, really hard to go to sleep. And we always had an ongoing struggle with at least one kid who didn't want to sleep in their room. They wanted to sleep on the couch in the living room or in the staff office. And it doesn't take much imagination as to why that might be, that it might be impossible to relax enough to fall asleep if bedrooms are where bad things have happened to you. So we would get into power struggles with these kids, not really having a grasp on what it was that was actually happening. Avoidance, this used to be called constriction, if I've got any OG people in the room. But starting with the DSM-5, they started calling this avoidance. And it's pretty straightforward, right? It just means I'm going to avoid anything that I think might threaten my regulation or my ability to avoid being triggered. So that might mean that someone makes their life smaller and smaller and smaller to do that. And like many things with trauma, the problem with that is that it does tend to generalize and ripple out. So imagine that I'm a veteran and I say, I don't go to the fireworks because it is too triggering. And again, you'd be like, good plan. But if I'm not getting help with healing that trauma, it can start to generalize and ripple out. So now it's, well, I don't like to go to anywhere where there's crowds, so I'm not going to go to the jazz fest. Okay. And now I can't go to a mall. And now I only do my grocery shopping at 4 in the morning at Walmart. I've always thought if you go to Walmart at 4 in the morning and you see people there, you'll see a lot of people who work kind of funky shifts, and you're going to see some people who are there because of their PTSD. Um, it can also sort of shorten or constrict emotional range. A perfect example of that is an interview I saw with a veteran who said, before I went to war, I had a normal range of human emotions. And when I came back, I only had two emotions, numbness and rage. So we can see that avoidance start to also limit someone's emotional kind of range. And it can also result in rigidity. So again, talking about autism as an example, you have some folks who are rigid for lots of reasons. Some of them might be, or there may be some overlap with, I feel safe when I have routine because I know what to expect, and something unexpected triggers my hypervigilance. And so I get very avoidant about change. You can see how these sort of, ping pong off each other. Intrusion is what we usually think of when we think about PTSD. So things like being triggered or nightmares. Typically, what we would describe my professor as having in the movie theater is a flashback, which is an intrusion into the current moment. But it can take it can take the form of thoughts or memories or dreams. Interestingly, we do not have any medications that directly treat PTSD. We mostly have things that can help with symptoms like antidepressants or anti-anxiety medications. But there is one medication that can directly help nightmares for some people. It's called prazosin. My experience working with people who've been prescribed prazosin, some people find that it really helps. Other people, it doesn't seem to do very much. So it's kind of a mixed bag. But we do know that people who have nightmares, they might benefit from trying that medication. And then the last one is sort of like classically PTSD. They made it really colorful and exciting language. Negative alterations in cognition and mood. This can mean a couple of things. It can mean, as we said, that people can have a lot of cognitive distortions as a result of trauma. I am not worth anything. People are dangerous. The world is an inherently hostile place. That kind of distortion. Mood, a lot of people have a lot of anxiety and depression when they are dealing with PTSD. So these are kind of common sense, but we do see them as well. So again, if you see someone who has been diagnosed with PTSD, they had to have enough of these symptoms in each of these four categories to get that diagnosis. And I've got, slides here that sort of go through them, but we kind of just talked about that. This is very important. And again, I suspect that a lot of you guys are very sensitive to this already. But I always try to bring this out with folks that are working with people with developmental disabilities. You may be working with people on the autism spectrum that are very verbal and very able to convey what they're experiencing. Although if they have alexithymia and they struggle with expressing emotion, that might be a little different. They may find it easier to use somatic descriptions. My muscles feel tight, maybe easier than I feel anxious. But you may also work with people who do struggle with verbal language or who may not have any verbal language at all. And that, of course, means that we have to watch them much more carefully for their somatic signals. And this is where getting medical assessments from a trained and skilled medical professional can be incredibly important, because what we may be seeing may also be physical distress from pain that's not been diagnosed. I remember working with a provider agency who had a young person who was on the pretty high needs on the autism spectrum, and he was doing a lot of head banging, and someone finally suggested that he get a full medical workup, and they found that he had badly impacted sinuses. And what at least some of the banging might have been was to try to alleviate that internal pressure. So when people are not able to verbalize what's going on with them, we need to be even more sensitive to signals that we may be getting. And I'll throw one more thing in here, especially for any of you who might work with school-age kids. A thing that I used to hear a lot, I think I hear it in the adult world as well, but certainly in the kid world, is someone saying, oh, Lara's just acting out. I hate that. I hate that. And I want to acknowledge I may very well be doing stuff that is very difficult or very challenging or scary or just plain weird. I started my career as a part-time student working with teenagers in a mental health setting. And I never want to sound like I am minimizing how challenging and confusing some of our folks can present at any given moment. I get it. But when I worked with staff when I was a clinical director, I would insist that if they wanted to use the phrase acting out, they had to insert the word it. They were only allowed to say, Lara is acting it out, which conveys something very different, I think. What it conveys is Lara is showing you on the outside what things are feeling like on the inside. And while that may be sort of a subtle shift in the language, I think that's a really powerful perspective that however much of a pain I am being with you at any given moment, it's worse in here. Nobody's doing that because they're having a great day, you know? So that's just a note that, again, I think I'm probably preaching to the choir. I think you guys are already very sensitized to this, but I always think it's important to include when I'm talking about developmental disabilities of any kind. We're going to talk briefly about this, and then we'll find a moment to pause where we are, and then we'll pick everything up to finish up next week. So those of you who are familiar with trauma, or even just in the general population, we've all heard fight or flight, right? And that really just means we're being mobilized for safety. We are getting ready to do something physical to make the threat go away. We're going to fight it, or we're going to run away from it, or whatever. Pretty standard, pretty commonly understood. But there are actually 4 reactions when we are in that mobilized state, not 2. And fortunately, they've got this common letter thing going on, so we could call them the 4 Fs. Fight or flight we're pretty clear about, so now let's talk about freeze. And I am hearing people talk about this more. I've noticed in the past few years, I think this is becoming more commonly recognized. So freeze means, just like it sounds, I'm suddenly going to be very, very still, but I'm still at a high level of activation, okay? So I always explain this as like the rabbit that darts in front of your car and the rabbit freezes, but that rabbit's not like, hey, what's up? That rabbit is practically vibrating with tension. Those muscles are still very much twitching to get out of there. And the second that you swerve out of the way, what does that rabbit do? It doesn't lay down in the middle of the road and take a nap. It bolts off, right? So it is stillness. And the strategy there is, let's say that I'm a rabbit, I'm a prey animal. If I'm still, a lot of predators like hawks will see movement. So if I'm still, maybe they won't see me, right? So still a reaction, a survival protocol written into the DNA. It's different from collapse, which we're going to talk about in a minute. So there's freeze. And sometimes when I work with people, if they froze in a moment where some trauma was unfolding, they may have a lot of anger or guilt about that. But as we will talk about briefly today and a lot more next time, these reactions are much faster than the thinking brain can keep up. There's a reason why I said reaction and not response, because at this stage, nobody's responding, they're only reacting. It's not quite, but almost as quick as a reflex. Okay, it goes a little bit further up into the brain. A reflex really only gets up to about the brainstem and then goes back down the spinal column. So it's a teeny bit faster, but these are unbelievably fast. You have started into this state long before your conscious brain recognizes where you are. So it is not a choice, it's a reaction. And the 4th one, kind of keeping with our animal theme today, is fawn. And unfortunately, it's not like an adorable baby deer. Fawn here means moving closer to a threat to neutralize it. And so, of course, this relates the most when the threat is coming from another person, which, again, for most of us, most of the time, that's what we're dealing with, right? So what that might mean is that somebody is doing something that we are finding threatening or that triggers that reaction in us. So it might be, let's say, anger. Someone is angry and I'm triggered into a fawn reaction. What that might mean is that I might actually move closer. I might smile or laugh. I might become very placating or passive or appeasing. I may flatter them or even become flirtatious or sexual or whatever it is. to try to calm them so that I can feel safe. Now, this is behavior that's already socialized for women, so we do tend to see it more with women, but men are absolutely capable of doing the same thing. And again, this is kind of why I made that point earlier. This happens much faster than I can think. I am not choosing or deciding to do that. Now, that might be a choice or a decision that I might make at another moment, but in that moment when I'm triggered, it's a deeply written ancient protocol in my nervous system, and I am reacting. My conscious brain will catch up perhaps and recognize that's what I'm doing, but I did not make that choice. So those are the four there: flight, fright. No, this is always tricky. Fight, flight, freeze, fawn. That is when we're mobilized and activated, which we'll get into the science of next time. But I'm going to wrap up today with talking about the other end of that spectrum, and that is when we are shut down for safety. So mobilized for safety, that adrenaline is pumping, and we're like this, and we're gonna do something to get away. So I'm a rabbit running away from the wolf. Okay. Shut down for safety is at the other end of that spectrum. So now let's say I'm the rabbit, but I've been caught by the wolf. What is a rabbit going to do? Well, it might struggle at first to see if it can get the wolf to drop it. But if the wolf won't drop me, then what do? Am I stiff like a board? No, the rabbit goes limp, right? Now, sometimes a predator might drop the prey and then the prey will get up again, but it'll take a second, because what's happened is the nervous system has gone in the opposite direction and it's kind of cut the power. So collapse may seem like the same thing as fawn or as freeze, but freeze is like this, very stiff and tense. Collapse can look numb. The muscles are soft. The body may literally kind of fold in on itself. If you have folks who go into a fetal position or they're rocking, they may be in a state of physical collapse. So the example here might be that when we are in our 4Fs, it's kind of like there's a fire in the building. And so the alarms are going off and the lights are flashing and you can hear the fire truck running down the street, and you're going to try to do what you need to do to get out of the house. Collapse and dissociation is more like the power's been cut and the house is cold and dark and there's nothing happening, right? So there's safety in the sense that nothing can get in or out, but there's no activity. And we also see that in the form of dissociation. We'll talk more about dissociation next time, but I will just say that it can sound like this big dramatic thing, right? Like I wake up in another city. And in its most extreme manifestations, there are people who can experience that, or I'm somehow missing time. But dissociation is often a lot more kind of everyday. And it simply means that two things that are usually connected are now apart. So that might mean something as simple as when you're driving home from work and you're thinking about this brilliant training you went to, and you realize that you kind of weren't paying attention for the last few minutes, but you were sort of automatically driving. That kind of autopilot, which is what we call it in our common language, is a mild form of dissociating. Or something that's more common might be for trauma. Someone starts telling you a traumatizing story, a trauma that they experienced, but they're telling you with no affect, right? I had this experience once working with a gentleman who was a political asylum refugee and had been tortured. And I had absolutely not asked about that. I think I'd asked about something like, how are you doing? And it was as if he hit the play button and he just started talking. And the things he said were so distressing that it was hard for me to be in the room. But he talked as if he was giving me a grocery list. Now, a tricky overlap here for folks that are on the autism spectrum is that some of them lack affect when they are talking. And so they may be speaking in that way, and it's not because they're dissociating from a trauma, it's because of other features of autism. And so again, I'm not going to say that everyone who does that was traumatized and it's always dissociation. I'm simply going to say that I do think can create some overlap with the population that you work with. That what might just look like the low affect of autism or any other developmental disability that includes that, it could also be, or it could otherwise be, someone who is dissociating from the feelings of what they're saying. So we will dive back into some of the details of what is going on neurologically when people are in this mobilized or shut down state. But I want to pause here so I can kind of check in with you guys and any of the comments or questions that you guys have about what we've done so far. Oh, someone came up with Ohio MAH. Thank you very much for that, Michelle. That's very helpful. Apologetic, Eugenia, yes, example, a perfect example. When people are, I'm sorry, I'm sorry, I'm sorry, even when they clearly are not the person who needs to be apologizing. That's a beautiful example of that. So I think what we're going to do is we'll go ahead and wrap it up here and let you guys get on with your day. But again, if some of you are working on a big question you didn't get to put in there, please either send it to us or make a note of that and let us know for next time, because it's always really great and helpful and adds to my knowledge when I get to hear from you guys. So with that, I'm gonna let this go and I will see you guys.